Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Colin Ellis, a respirologist and sleep medicine specialist in Saskatoon, discusses obstructive sleep apnea, including epidemiology, diagnosis, pathophysiology, and recent developments in training modalities. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thank you for the introduction, and thanks for inviting me to speak this morning. So let's get into it here. So I don't have anything to disclose. I'd like to do a land acknowledgement. So as we gather here today, we acknowledge that we are on Treaty 6 territory in the homeland of the Métis. We pay our respect to the First Nation and Métis ancestors of this place and reaffirm our relationship with one another. So these are my objectives for the talk. When I was communicating with Dr. B via email, he said that it's been a little while since the anesthesiology department had a talk about obstructive sleep apnea. He estimated around 5 to 10 years. So I wanted to focus on, the basics of obstructive sleep apnea, diagnosis and treatment, but also discuss, some new advances that are in the field that are helping to explain, maybe why people have sleep apnea, or maybe trying to more personalized therapy, and also evaluate some new treatment modalities that have been in the news lately. So what is obstructive sleep apnea? So basically, how I explain it to patients is that obstructive sleep apnea, whenever you fall asleep, all of us have some instability in our upper airway, and that leads to some flow limitation. And it's that in some people, the flow limitation is too much, and either the airway closes off completely and you get no air into the lungs, or the airway closes off, partially, but it's just you can still get air into the lungs, but not enough to sustain you. And that leads to oxygen desaturation. Your body does treat that as an emergency, and it does whatever it can to wake you up, so it leads to sleep fragmentation. And then with that entire process going on, it leads to catecholamian surges, which seems to drive some of the associated conditions. And so I think, we're all pretty familiar, like obstructive sleep apnea is very common. And a lot of the symptoms of obstructive sleep apnea are well known by medical providers and by the public. There's the stop-bang criteria, I think, are well established in the anesthesia field. And that all seems to make sense. If you get closed airway, you will have more snoring because of vibration of the soft tissues there. People generally will be tired, but or at least it was thought that most people were tired, but now we're seeing more and more that the vast majority of people who have obstructive sleep apnea are not excessively sleepy, like this boy here who is from the Pickwick papers, and is the inspiration for Pickwickian syndrome, which we won't actually be talking much about today. But so these are the typical symptoms. So why does OSA matter? So obstructive sleep apnea is the most common respiratory disorder. It's extremely common, and it has a well-established association with heart and stroke. It also has associations with reduced health-related quality of life, which, as we'll see, is still the best reason to treat someone for obstructive sleep apnea. People with obstructive sleep apnea tend to have increased mortality. And then there's also like a public risk with obstructive sleep apnea, where there's more motor vehicle accidents, more workplace accidents. And, treatment of obstructive sleep apnea in certain cases, especially when it comes to things like motor vehicle accidents and workplace accidents, can reduce the risk of those things. And then, of course, for anesthesia, there are anesthetic considerations for patients who have obstructive sleep apnea. So unfortunately, despite, a fairly good knowledge of the symptoms of it, and it being so common, it is still underdiagnosed. So there's a lot of people out there who have obstructive sleep apnea. They've had it for years and they have yet to be diagnosed. And those patients are going to be coming in for surgeries. There is, a good body of evidence that associates obstructive sleep apnea, predominantly moderate and severe obstructive sleep apnea, with greater postoperative cardiac and respiratory complications. Sometimes OSA and its associated conditions such as obesity hypoventilation syndrome, which is, I guess, can be conceptualized as like end stage obstructive sleep apnea resulting in hypercapnia, as well as, OSA COPD overlap syndrome, where someone who has COPD that may not be, severe enough to cause hypercapnia on its own, but with the combination of obstructive sleep apnea can result in hypercapnia. And they have greater risk of postoperative complications as well. When you're, going for your procedure here, there is an increased incidence of difficult airway or inability to provide adequate mask ventilation. And you can see here, this is a graph that has summarized some data from a large database of patients undergoing general surgery. And you can see that in patients who have obstructive sleep apnea versus those who don't, there's a greater risk of respiratory complications there. So it is an important topic. It is a global health problem. So recent estimates indicate that about 1 billion people worldwide likely have obstructive sleep apnea to some degree. If you use more stringent criteria for obstructive sleep apnea, such as including only moderate patients, then that number goes down to about 425 million. But it's still quite a big problem. It's estimated anywhere between 15 to 30% of males and 10 to 15% of females in North America, or adult males and adult females in North America, have sleep apnea to some degree. And it has been steadily increasing over the last few decades, and that's thought to be due to the increasing rates of obesity. There has been, historically, obstructive sleep apnea was described in men, and it had kind of a male-centric, symptomatology and treatment strategy. So, the typical person with obstructive sleep apnea, is an overweight adult male with like a large thick neck who has a lot of apneas and desaturates a lot. It's now being found that, if you're applying that same framework to women, then you're going to miss out on a lot of the symptoms of obstructive sleep apnea, and perhaps you won't be even diagnosing them properly or treating them properly because you're not really targeting the correct symptoms. So there was the most recent, so the standard that we use to diagnose obstructive sleep apnea comes from the American Academy of Sleep Medicine, so the AASM, and they're the ones who have, provided the diagnostic criteria with regards to what constitutes an apnea, what constitutes an hypopnea. And, a few decades ago, you needed to score a hypopnea. You had to have, a greater than 30% reduction in airflow, and then it could either be associated with an arousal from sleep or a reduction in oxygen. And that reduction used to be 4%, but as of 2012, I believe that number was increased to 3% or reduced to 3% to make it more sensitive. Unfortunately, there's still some places, apparently, like in the United States, that haven't adopted that 3% criteria. And a recent, study came out that showed that if you apply the 3% criteria and the 4% criteria to both men and women, that by applying the 3% criteria to women, you get a greater increase in diagnosis of obstructive sleep apnea compared to men. So it is still underdiagnosed in women, and at least in the United States or anywhere that uses that 4% criteria, they are still being discriminated against, I would say. So OSA overall is more prevalent in men throughout life. It increases the risk increases in pregnancy, and then it increases after menopause. Whereas after menopause, the difference, like the incidence rates between sex, doesn't matter anymore. Women who have obstructive sleep apnea don't present so often with loud snoring or witness apneas, and they aren't oftentimes as sleepy during the day. That doesn't mean to say that there aren't women that don't have those symptoms, but these are symptoms that are commonly seen in women, but they might present more with just general fatigue, insomnia, predominantly sleep maintenance insomnia, where they can fall asleep just fine, but they wake up frequently during the night and then can't fall back asleep, or early morning awakenings where they can fall asleep fine, sleep until early in the morning hours, and then they'll be awake far before they want to be awake, and then that results in unrefreshing sleep and um, poor quality or poor satisfaction with the sleep. And it presents more often with depression and anxiety. So how do you diagnose obstructive sleep apnea? So diagnosis of obstructive sleep apnea can't be made on clinical history alone. You need to do a test to prove that someone has obstructive sleep apnea. And there's multiple ways that we can diagnose them now. The most common are with what we call a level 1 polysomnogram, which would be this individual in the bottom picture. It's a fairly involved test. The patient has to go to either a sleep lab, at least in Saskatchewan, they go to City Hospital in Saskatoon, or they go to the General Hospital in Regina. They arrive there around 8 and they get connected to this whole get up here. There's leads that you use to record the EEG. You have these eye leads here that you can use to identify REM sleep in combination with this lead here that is recording chin EMG. There's the prongs in the nose that record airflow, and a thermistor as well. And then there's belts across the abdomen, belts across the chest. There's usually some leads that you can attach to the legs that can look for leg kicking overnight. And sometimes if someone is acting out their dreams, you can attach leads to their arms. I think that's all the leads that, at least in just like a standard level 1 sleep study, that you will perform. Those are the standard leads. So it's a fairly involved test. It collects a lot of information, but ultimately that information is just boiled down into the apnea-hypopnea index, which is the number of choking episodes you have divided by how much time you sleep. The people who can order these level 1 sleep studies in the province is limited. They usually want it to be someone who is perhaps specialized in sleep. So, typically in Saskatchewan, that's a respirologist. Some psychiatrists can order them as well. And it's oftentimes open to neurology. So those will be the people, if you want a level 1 sleep study, that you would have to speak to. Then the most common way, however, how people are diagnosed in this province is with a home test, or what was called a level 3 test. So this is a more simplified version of the level 1. So it usually consists of 4 readings. There's the flow signal. They have this belt here that measures respiratory effort, and then they have the oximeter that measures oxygen saturation and heart rate, or pulse, I guess. And it's more convenient for the patient because they can do the test in the comfort of their own home. There's less leads there. The disadvantages are that these tests have a high failure rate. So as they're sleeping, I forgot to mention with the level 1 study, there's sleep technicians actually at the hospital, and they observe you sleeping the whole night. And if one of the leads fails, or if they're having some problem with the technical quality of the test, they'll remediate it right at the time. Whereas if the pulse oximeter falls off your finger within the first 10 minutes of sleep and you don't wake up the rest of the night, then it's a wasted test and you have to do it again. There's also a risk of underdiagnosis using the home sleep apnea test. So how you generate the apnea-hypopnea index in the sleep lab is by taking the number of choking episodes and dividing it by the hours of sleep. So there could be times when the patient is not sleeping, and then you would just exclude that from analysis. Whereas with the home test, there's at least the level 3 test, there's no way to determine if someone is sleeping. So you take the number of choking episodes and divide it by the amount of, or the recording time. There is an in-between test called a level 2 test, which is an at-home version of the level 1 with a simplified EEG and that is used by one of the private CPAP companies in the city here. But it's not widely used there. It fills a very small market. There's a newer home sleep apnea test that we'll talk about on the next slide that's based on well, I guess the ones that are used here or the ones that are used in research are mostly based on photoplethysmography, which has been around for a while, but it's kind of the analysis of the signals there. And some take it a step further and use peripheral arterial tone. But what is inadequate is just a simple overnight oximetry or just the clinical evaluation. So basically what we're looking for here is, I have it here. So this is what a level 1 sleep study looks like. So it's a bit messy, as you can see, because they collect a lot of data, but ultimately they have, this black up here is the EEG. You have EKG here. There's the eye leads. This is the snoring here. And then you have the chest and abdominal belt. So if you want to really diagnose sleep apnea, you're looking at chest, abdomen, nasal pressure, thermocouple, and SpO2. And you can see here that when someone has an obstructive apnea, they have complete cessation of airflow while they have ongoing effort. And then ultimately, that happens, it's happening for, over 10 seconds. And then finally, they're able to either they're having arousal, and then they wake up from sleep. They can breathe normally for a few breaths. They fall back asleep, and then that repeats itself. You still have respiratory effort, and finally you break through that. You have an arousal, and all the meantime, your oxygen levels are dropping. You can see that this individual has it frequently during the night. This is what a home test would look like. So this is an example too of hypopneas. So you can see that with the nasal flow here, they're having reduction in airflow that's greater than 30%. They're having ongoing respiratory effort. And then finally, they can break through that obstruction, usually with a cortical arousal that allows them to breathe normally, and then they fall back asleep and it repeats itself. And it just keeps repeating itself during the night with these recurrent episodes of oxygen desaturation. And, I guess what's not really measured by us is the, catecholamine surges, but that's also happening as well. So this technology, this PPG or peripheral arterial tone technology, is being used more in I feel like in the United States, but there is a company that operates in Saskatoon and I guess throughout Canada that's using newer technology that takes advantage of analyzing signals obtained from PPG. It's called cardiopulmonary coupling. And essentially, it's a bit complicated, but PPG has been around for a long time, and we use it most often for determination of the oxygen saturation. And it uses the pulsatile flow in the finger to see how much light it absorbs. And using that signal and using the synchronization between heart rate variability, blood volume, and I guess therefore respiratory variability, and then how well they are synchronized with one another can, it turns out, help determine what kind of stage of sleep someone is in, whether it's in not the classic stage 1, stage 2, stage 3, but they can find that there's light sleep, which is fragmented sleep that's oftentimes associated with sleep apnea, versus deeper sleep, where that's not oftentimes associated with sleep apnea, and it can help diagnose obstructive sleep apnea that way. So that's a newer technology out here, and some of the data, like the sleep imaging, is the one that's used by the company here. It has pretty good data that it has good agreement with the AHI that's generated from a level 1 sleep study. So it is useful, and it's a lot easier for the patient to use. It's just this little ring. So the ring isn't the sleep image thing itself, but it's the software that they use to analyze the data obtained from that ring. So it is promising in that it's relatively less expensive than the home sleep test apparatus. It's a lot easier for patients to use, and it's less likely to fail, because you just have to put it on the finger. It fits there fairly tight. Because they can take it home, it's not as expensive. You can move towards a model where you diagnose sleep apnea based on multiple nights of data. So, there is some research showing that there is some variability in the night-to-night apnea hypopnea index. So if you are just observing someone on one night of sleep, then you're likely to, miss sleep apnea, or your miss characteristics of it, whether it's, very positional or not. If and then sometimes if you miss, a diagnosis of someone with significant sleep apnea, perhaps underestimate it and have that discussion with the patient. It won't be, years. It won't be until years down the road when they get another chance at being diagnosed, and then get on treatment their successful treatment. So I guess these types of devices are cleared for diagnosing sleep apnea. They can be used in a clinical setting to diagnose obstructive sleep apnea. They have kind of FDA clearance for that. They have the evidence to back it up for diagnosis based on how well they perform compared to conventional polysomnography. There's a lot of wearable devices out there that, and in the news lately, there's been news or clearance for certain wearable or consumer-facing devices, they're called, that can help detect sleep apnea as part of like a health promotion strategy. So they don't have any clearance to, say, diagnose obstructive sleep apnea, and what they generate doesn't correlate. It's not like an apnea hypopnea index, but and it's really hard to know exactly what they're using to generate that diagnosis or that suspicion for obstructive sleep apnea, because it's all proprietary algorithms, and so it's a bit of a black box. But one of the more popular devices like the Apple Watch has this new health promotion technology where it will analyze your sleep over the course of, say, like a month, and it actually doesn't use that, even though like some of them do use that PPG technology. It uses the same technology that you would typically use for actigraphy, which is how you can estimate sleep typically based on periods of rest versus not. And they have fine-tuned the algorithm currently to help detect more moderate to severe obstructive sleep apnea. So basically, the person activates this feature on their phone or their watch, and after a month of the watch analyzing their sleep, then it would send them, if it was suspicious for sleep apnea, it would send them this link saying that they should go talk to their doctor about getting tested. Based on how their algorithm is currently, it seems to be fairly specific for moderate to severe sleep apnea. It's not as sensitive, so if your watch isn't telling you that you don't have sleep apnea, then and you still feel like you do, then, or you have symptoms, then it's still worth it to get checked out. But this is kind of looking down towards the future. Like, there's a lot of wearables out there, and a lot of them are going to be having more of these features in there, which may help with screening for this. So next, I want to move on to discussing endotyping of obstructive sleep apnea, which is one of the kind of newest things that has come out that is being more widely accepted, as being important for how we think about obstructive sleep apnea and how maybe we'll treat it in the future. So historically, obstructive sleep apnea was thought as strictly an anatomic problem, where either related to the craniofacial anatomy or obesity. You just really have no room there when you fall asleep. The airway just collapses in, and then it's stuck there, and that's why you have sleep apnea. We now know that sleep apnea is a bit more heterogeneous than that, and out of a lot of research, there's been 4 distinct endotypes that have been identified that can help explain sleep apnea. It's thought that about 70% of people have more than one of these endotypes that explains why they have sleep apnea, and it can also explain why some people, like maybe someone who like why on, say, like a bariatric wait list, only half of the people have obstructive sleep apnea. It explains why some of those people don't have sleep apnea. And these do, down the road, like if obstructive sleep apnea is present in 1 billion people worldwide, it seems hard to believe that they all have the exact same, presentation and treatment needs. And this will allow for more personalized therapy, hopefully sometime in the near future. So what are those 4 endotypes? So the first one that is fairly well known as the collapsibility, or just the crowded airway. So that one, is how we classically think of obstructive sleep apnea, and it is still included as an endotype. Here, there's people who have a low arousal threshold. So whenever we fall asleep, almost all of us have some instability in our upper airway as we fall asleep, but we're able to compensate for that. And typically, with arousals, as you're falling to sleep or getting into deeper sleep, as you go through stage 1 to stage 2, it's thought that there's some protective mechanisms that are activated in that pathway that allow you to stabilize your upper airway, get into that deeper sleep, and then, have, good quality sleep and not to have obstructive sleep apnea or those repetitive, hypopneas, arousals, and that sort of thing. Some people just have a low arousal threshold though. So with any sort of flow limitation, they'll have an arousal and then they'll wake up, then they'll fall back asleep. And then it's just this process that repeats itself. So that low arousal threshold that prevents you from getting into the deeper sleep where your airway is more stabilized is one of the endotypes. This endotype here is for people who have high loop gain. So loop gain is typically discussed more when you're thinking of central sleep apnea, and especially Cheyne-Stokes respiration. But essentially, it's an engineering term that describes the response or the magnitude of a response to a certain stimulus. Those with a high loop gain will have a large response to a small stimulus, which promotes an unstable environment, or in this case, an unstable breathing pattern. So if you have a small disturbance, then have a massive response due to that, then that will result in unstable breathing and cortical arousal, light sleep, and then that's a process that will be ongoing. This is a target for medications, things like acetazolamide or even oxygen therapy has been proposed to help manage this, both in obstructive sleep apnea and central sleep apnea. And then the last of the 4 endotypes is individuals who just have poor muscle activation while they're sleeping. So I think I have, here. So you can see in this patient here, so this is, an example of minimal genioglossus muscle responsiveness. So this person is having an obstructive apnea, and you can see here that they are still having ongoing effort. And then here with the EMG, if you're looking at this one here, this is the EMG of the genioglossus muscle. And as they're having an obstructive apnea, even though they're having ongoing effort, they're not increasing the tone in their genioglossus muscle. So that's, if you're not increasing the tone there, then you're not going to relieve the obstruction. And then ultimately they have an arousal and that breaks the obstruction. Here is an example of what it should be like. So this person's having an hypopnea, not an apnea, but they're having respiratory effort. And as that respiratory effort is increasing, the output to the genioglossus muscle and the activation of the genioglossus muscle is increasing. And then ultimately it increases enough where this person does not have an arousal, but they're able to restore airflow and continue sleeping soundly. So despite having this obstruction, there's no cortical arousal, there's no oxygen desaturation, and the body was ultimately able to compensate for that obstruction to relieve it and allow the person to keep sleeping. So this is a representation of how, endotyping contributes to sleep apnea in different individuals. So for someone here, this would be entirely due to like anatomic compromise. So that's how we typically think of obstructive sleep apnea, or at least have historically thought of obstructive sleep apnea. And then you can see here with different endotypes layered on top of that, how someone might not have a lot of, anatomic obstruction or, airway compromise that way. But if they have that, plus they have increased loop gain, plus they have reduced muscle responsiveness of the, genioglossus muscle or other pharyngeal dilators, and then they have a low arousal threshold, then that person can have obstructive sleep apnea. And then, viewing it this way shows why it's not so, it's not a wonder why things, certain things that, intuitively should work, like say upper airway surgery, do work because, you can remove that anatomic obstruction, but you're not addressing all of the causes of obstructive sleep apnea in that person. So this is where, like, this is a very promising area. It hasn't really changed management currently, but it's becoming more and more of an active research area where things are coming out where you might be able to use things that will target these different pathways, such as, maybe sedatives that will help increase the arousal threshold, further reduce muscle responsiveness of the genioglossus muscle or the pharyngeal dilators. There are medications that are coming out that can increase the tone. And then loop gain, it's been known for a long time that things like acetazolamide can reduce loop gain and stabilize the breathing, and same with oxygen therapy. There's also a shift beyond using only the AHI to define obstructive sleep apnea and who should be treated and what are the targets of treatment. So you're now more or less you're trying to identify, different obstructive sleep apnea subtypes and different individuals or different populations that might have characteristics that would respond better to obstructive sleep apnea. It's probably no secret now that, there's been three randomized controlled trials trying to determine if, obstructive sleep apnea can reduce, a composite endpoint of, cardiovascular events and death. And all of those have failed to meet their primary endpoint. And, there's a number of issues there where, patients in those trials didn't really wear their CPAP all that much. But there's also a thought, beyond, the issues with the trial and adherence and that, but are they selecting the right patients, or is the population too heterogeneous to actually determine if you're using the right therapy for those people? So, there's different things that have been proposed. They're not anything that we can really use in the sleep lab right now. But it's something that, as newer technology comes out, there might be different signals that we can use or that we can derive from the PSG data to help have those conversations with our patients. Some of those things from the sleep lab would be, is how much does someone spend desaturating, during their sleep study when they're having obstructive events. That's what the hypoxic burden is describing here. So you can have one patient who, maybe has a lot of short hypopneas and they have frequent arousals. They could have a very, very high AHI, but their oxygen level may never really get below even 88%. On the contrary, you can have someone who has very long obstructive apneas, upwards of, 45 to 60 seconds, where their oxygen levels go extremely low. But because these apneic events are so long, their AHI is actually a lot lower than the other person. But clearly the person who is desaturating deeper and longer than the other person, appears to be at a higher risk. So it's just something you can use to discuss with people. The obstructive sleep apnea or treatment of it with, CPAP or even a mandibular advancement device has been shown to reduce blood pressure. And that reduction in blood pressure is greater in individuals who, actually have uncontrolled hypertension. So that could also be a target. And then depending on the symptoms someone has, they have different responses to therapy. So instead of just considering, obstructive sleep apnea as like a one size fits all condition where, you are excessively sleepy and you need to be treated. We do know that those people who have excessive sleepiness have the highest cardiovascular mortality. They also respond the best to therapy. But there's other people who have, no symptoms at all. They're maybe only moderately sleepy, or maybe their sleep is just disrupted in some way. And, maybe different treatment targets are needed, or maybe they have different endotypes that will result in the need to use more personalized medicine for those people. So next, I'm going to move on to treatment here. So what are the goals of treatment for obstructive sleep apnea? So the best reason to treat obstructive sleep apnea is still to improve, patient-reported outcomes. So why does the patient get tested for sleep apnea in the first place? And what are their specific goals for being treated? Excessive daytime sleepiness is, oftentimes considered to be the best predictor of response to treatment for obstructive sleep apnea. But also people tend to want to improve their vigilance or their cognitive function during the day. There's a lot of people who have problems with interrupted sleep and they want to reduce the frequency of that. A lot of people just want to sleep through the night. There is a lot of people who are referred for loud snoring and apneas, and that's either observed by, say, like their spouse or by the anesthesiologist in the postoperative unit. And especially apneas is one that, patients really don't like to, there's certain patients who really don't want to be having apneas overnight. And especially if they're having choking episodes, they want to resolve those. So oftentimes that can be used as, fuel to, treat sleep apnea and get them on, CPAP or maybe an oral appliance. A secondary outcome is to reduce the AHI. So we still, with the AHI and all its faults, we still do target a reduction in the AHI because that is currently our best way conventionally to measure obstructive sleep apnea severity. So, standard CPAP machines for, I guess forever have been able to measure a residual AHI, and you can use that, in addition to, the clinical review of the patient, but you can use that to see, how therapy is working for them and to make sure that their AHI is going down from, say, like 35 down to an acceptable level, usually less than 5, but it all depends on the patient and how they're feeling. You want to achieve adequate adherence so that the patient can get full benefit. And we'll talk a bit about adherence a bit later, but, if I tell people all the time, like if you only take, your blood pressure medication 50% of the time, you're not going to really be able to expect that your blood pressure is going to be treated. It's the same with CPAP or your oral appliance and sleep apnea. But, unfortunately, if you're not wearing your CPAP device, you're still going to have obstructive sleep apnea. So it requires a lot more buy-in for a patient and a lot more commitment on their part to use the CPAP device, because it's not as easy as just taking a pill and then going to sleep. This is something that they have to use, during ideally all hours of sleep every single night, or else they'll still have sleep apnea. And then as the last outcome, you want to improve associated comorbidities, and oftentimes that's things like high blood pressure. There are still a lot of people who do want to use CPAP because of its association, or because of this association of obstructive sleep apnea with things like heart attack, stroke, heart failure, death, and that. And there's some observational data out there with like very large numbers of people that would, support the use of that in that scenario, where people who use their CPAP device tend to, live longer, have less heart attacks, that sort of thing. So we'll first talk about CPAP. So CPAP is considered to be the first line for obstructive sleep apnea, at least in North America, but I guess throughout the world, it is the first line therapy. And the reason it's first line therapy is that it is the most effective therapy, and it has essentially no side effects. Like CPAP, like there's, everybody can be treated with CPAP. If you put them on CPAP and get, and titrate the pressure as high as you can go, you ultimately will relieve obstruction in the patient. The main issue is that, there's a lot of people who are unable to accept CPAP as a treatment due to a number of reasons, but it is the most efficacious thing. There's good treatment pathways currently to help get someone on CPAP and help for reimbursement to CPAP. So that kind of makes the process of starting someone on CPAP, a lot easier if there's already streamlined pathways there. And with CPAP as well, the patient can, usually what you'd like the patient to do is to try it first, because, the best way to know if someone's going to respond to treatment of sleep apnea with CPAP is to use it. And usually you want them to use it for a good chunk of time, like a few months. But, things are expensive these days, and CPAP, sometimes people are charged, a couple $1,000s for these, plus the cost of the mask and the tubing and that. So, sometimes helping someone or getting someone to try it first to see if it's something that A, they can get used to and use while they're sleeping, and B, will improve their symptoms, and you can do so at a lower cost. So there's a number of reasons CPAP is first line therapy, but this is typically where you start with people. And it's, has pretty good evidence that it will take people who are sleepy and improve their sleepiness. It'll improve their sleep-related quality of life. There's pretty good evidence that it'll improve hypertension as well. The typical person you want to start it in, or the typical candidate for treatment, is someone who has a AHI above 15. This is typically where, either private payers or even like provincial payers will reimburse patients for CPAP. Whereas oftentimes if they have an AHI that's less than that magic number of 15, so like mild sleep apnea, they can run into challenges with their insurance or getting appropriate coverage for that to use it. Although we do know that there are people who have mild sleep apnea who feel much, much better once they get started on treatment. So how do we typically start someone on CPAP? So you have to provide a lot of education for, what is sleep apnea? Why should you use a CPAP machine? What is it? What to expect? That sort of thing. There's some data that indicates that if you actually show the patient their sleep study and show them when they're having choking episodes and how much they're desatting, that they actually improves their adherence to therapy. So typically when we're in the sleep lab, we try to get patients into the room to show them their study so that they can have buy-in as well, because it seems, so obvious to us when we're reviewing it why they should be on treatment. You can either start them with an auto CPAP trial where you send them out with, a couple masks, and typically it's a combination of a nose mask and a face mask, so that they can try either to see what's more comfortable. And then the machine has an algorithm where it can detect upper airway obstruction and auto adjust its pressure to help relieve that obstruction throughout the night, so that the patient doesn't even need to have like a set CPAP. They just kind of get put on this auto CPAP and they can try it at home in the comfort of their own home in their own bed. Another option we have to start on is just bringing the patient back to the sleep lab. They still have to get in that same hold get up that I showed you before, where they get the wires on and all that. But instead of having just the nasal cannula in this time, they have like a CPAP mask on, and you can observe them through the night having episodes of obstructive sleep apnea. And then you can titrate the CPAP, by 1 or 2 centimeters of water pressure to help relieve that. And you can find what the optimal pressure is for, their sleep apnea, whether it's, in supine or non-supine sleep, or REM or non-REM sleep. So that brings us to CPAP adherence. So there's 2 different patients who, broadly 2 different patients who have CPAP. There's ones who don't use it at all and would like to just throw it across the room, as they tell me, or put it in the closet, put it in the garbage. And then there's those who take it wherever they go. You can take it through airport security these days. What you try to tell people is that CPAP is dose dependent. So the more you use CPAP, the more benefit you'll get from it. There's this kind of arbitrarily defined optimal adherence to therapy, which is considered to be, more than 4 hours on 70% of nights. It's not really clear where this initially came from, but certainly the CMMS in the United States uses that as their reimbursement criteria for CPAP, and it's just been kind of widely adopted. You'll see even on CPAP readouts that you're looking at that they'll use, the number of nights with greater than 4 hours of usage, and people refer to that 70% of nights very often. But that's not a one size fits all thing. And clearly, if you use CPAP more often, you're going to get more benefit from it. And then we do know that adherence in trials is very poor. And we'll just say that with the caveat that, mostly in trials, they enroll people, or they feel it's unethical to enroll people who, have a lot of symptoms and who would benefit from sleep apnea. So those who are, particularly quite sleepy. So CPAP in those 3 randomized controlled trials that looked at cardiovascular outcomes was around 3 hours per night. So it was quite low. But the interesting thing is that even though the adherence was quite low, that they still, when they did their questionnaires later, they still had reductions in their Epworth sleepiness score. They still had improvement in their scores on, health-related quality of life. They had reduced rates of depression and anxiety. So even with a small amount of CPAP usage, and even though they weren't, quote unquote, symptomatic at baseline, they still had improvements in a number of things. So the adherence targets tend to vary based on what symptom you're trying to treat. So you can see here where if you're trying to treat sleepiness, then maybe you only need to use it for 4 to 5 hours a night. Obviously, if you use it more, you'll have more benefit, but there you have it. Compare that to improving your neurocognitive outcomes. You need to wear it for longer than that. If you want to use it for depression, then it can be lower, and hypertension is still around that kind of 4-hour mark. So looking at, 20 years of data for this is looking at clinical trials, and they haven't found that, despite what, we would like to think with changes in, machine settings, adding things like expiratory pressure release or more comfortable masks that may have like memory foam, and even trying to, have people during the trials, promote adherence. They haven't shown really any change in CPAP adherence over 20 years. So you can see this is percent of non-adherence to therapy, and it essentially has remained the same over the past, 20 or so years. So sometimes it doesn't feel like you're making a good, despite all these advances and what you're trying to do, you haven't really improved adherence to therapy. But this other trial looked at, real world viewers. So these are people who aren't in trials. So this includes people who are sleepy and are motivated to use their CPAP machine. And they found that with this is the CMS compliance criteria, the 4 hours and 70%. So, 75% of those met compliance criteria, analyzing, a large number of users with this program called AirView. And the mean usage was around 5.5 hours. So, that kind of fits more with what we, like to think we see in the real world, where, people are coming to you because they have a problem, they want to treat it, and with your help, they can get used to it. But it also highlights that there still are people who get prescribed CPAP who just can't use it. Some barriers would be, things that are pretty obvious, like if you're using a mask and your nose is congested, you have to treat that. People are claustrophobic, so they don't like the mask on their face. Sometimes using desensitization can help with that, getting them to use their mask during the day. They just don't have buy-in, so there's a lot of people who are sent because they're snoring, their spouse doesn't like it, and that's the reason they got tested for sleep apnea. And then those are people who are very high risk for not using it, or they don't understand kind of what's going on, or they're asymptomatic. And then predictors of success are those who are more severe, of daytime sleepiness, if they understand why they're using therapy, or if they're using a nose mask versus a full face mask. People who use nasal masks tend to use CPAP, for more like a longer time during the night. They tend to be able to use CPAP with lower pressures, and they tend to have less leak. So, oftentimes you see people go and they get the full face mask because they go to the clinic and they say that they are mouth breathers. And then they get put on a full face mask. But using a nasal mask will reduce your nasal resistance, and then oftentimes you'll stop breathing through your mouth. So I try to get people to use a nose mask as much as I can. And then trying to empower the patient to take responsibility for their own treatment and for their own health is oftentimes a very important and a very rewarding thing to do. You want to know how much someone will value treating their sleep apnea. You want to try to convince the patient that their own health is within their own control, and that the things that are happening to them aren't just due to random chance, but they can modify them, and that they do have the power to use this machine. It's not that complicated. There's lots of people who get out there and use it. So those are certain things that are modifiable, and if you can help support someone and give them positive experiences with it, then they'll oftentimes be able to adhere to it. And that's oftentimes what you do in clinic there. The second line therapy is typically oral appliance therapy, or otherwise known as mandibular advancement devices. And essentially, these are three different types of oral appliances. This last one here is a tongue retaining device. So you wear this overnight, you stick your tongue into there, and it like holds your tongue in a more forward position. But essentially, what the other three do is they have a block here on the maxillary portion, and then as you close your mouth, this triangular piece on the bottom portion pushes up against that, and it pulls the jaw and the tongue structure forward. And then this is a bit blurry picture, but you can see that there's a gap here, and there's little screws on there that the dentist can use to push that forward to allow for even more or maximal forward movement of the tongue to move it out of the airway. And that's essentially how they work. In general, they're not as efficacious for all comers for treatment of sleep apnea as CPAP, but they're oftentimes better tolerated by patients, and that's kind of where their value lies. There's no typically, because these things have to be custom made, there's no real way to get them to really try it, cost free, without, and then finding out, down the road that, maybe this isn't something that would work for me. But there are some predictors of success that you can use, and you can use that when you're talking to the patient and giving them, informing them of their options. And those are typically people who are younger, thinner, have smaller neck circumference, because then you feel like, or more supine dependent or positional obstructive sleep apnea, because that implies that the tongue is playing a greater role in the sleep apnea. But again, these aren't perfect predictors either. Usually people who have higher body weights, or who have larger neck circumference, and previously it was thought that if the sleep apnea is quite severe, then an oral appliance therapy is typically not considered. They used to say like a cutoff of AHI 30 would be a contraindication for for a mandibular advancement device. And then they have to have like enough teeth in certain area, like on their mandible, or I guess their maxilla. And it has to have good dental health as well. It has to be a customized device. So there's, if you go on Amazon, you can get like Boyle and Bite mandibular advancement devices, but those don't seem to work as well as one that is custom made by a dentist who is trained in this field, who can follow up with a patient and who can titrate it and ensure that they're getting like a sleep study done afterwards. So that's why if these things are going to get done, I like to refer them to dentistry and someone who's experienced in that field to do it, because they'll do it better, and that's backed up by data. So with that, this is the customized device, so the residual AHI is higher in the non-customized versus the customized. If you're using a non-customized device, at least in this review here, the SpO2 nadir didn't even improve, and there wasn't even improvement in a patient-important outcome, which is their sleepiness. And then when considering like a mandibular advancement device, even though it is less efficacious in general, you have to think of the burden of the disease, and that's where this metric, the mean disease alleviation, has come into play. Trying to justify using a less effective therapy, but for a longer period of time, will help in reducing the burden of disease to the same degree that someone who uses a very effective therapy for only a short period of time. So this is how you can compare CPAP, which is very effective but maybe not used all the time, to an oral appliance, which is not as effective but used for a longer period of time. You see the burden of disease would be the same. And when you can compare CPAP and a mandibular advancement device head to head, CPAP is more effective in general for the AHI and the oxygen and the gas exchange. But it is similar in reducing symptoms, improving driving, health-related quality of life, and reductions in blood pressure. So next, I just want to move on to obesity and obstructive sleep apnea, because there's been recent trial that has come out that has been able to give us another tool for treatment of obstructive sleep apnea. The relationship between weight and obstructive sleep apnea is well documented in multiple trials, and as like is very intuitive. As you gain weight, you're more likely to have sleep apnea, you're more likely to have more severe sleep apnea. And typically, as someone loses weight, they're more likely to have improvements in their sleep apnea, or their risk of sleep apnea is a lot less. This here is some cross-sectional imaging of a patient before and after weight loss. So you can see here his airway is quite narrowed at certain areas, and the total area is quite low. But then he lost about 18% of his body weight, and his airway caliber increased dramatically. And he had a significant reduction in his AHI from, very severe. So anything above 30 is severe. So he is almost double of what you would be considered severe, down to an area of around 15 events an hour, which is at the point where maybe you would consider treating this person or not, depending on their symptoms. So just with weight loss, you can substantially improve, obstructive sleep apnea, and just keep that 18% body weight loss in mind there, because this trial came out recently. So this is a trial for a newer medication called tirzepatide. I actually can't remember what its name is when it's used to treat obstructive sleep apnea, but essentially it's kind of taking medications like Ozempic and going one step further. It's a combination of a GLP-1 agonist and then another compound called a GIP agonist. And so that combination of compounds works even more to result in even more dramatic reductions in body weight. And the reason that this trial is so important, because they use this trial with a primary endpoint of improving obstructive sleep apnea through weight loss. So they did two trials. So in the first trial, both the control and the treatment group did not use CPAP. And then in trial number 2, both groups used CPAP. And then they gave them this medication. It was a randomized control, double-blind placebo trial that went out to 52 weeks. And then they did a sleep study, at the beginning, and then they did a sleep study at the end. They enrolled people who had BMIs greater than 30, and the average is around 39. You had to have an AHI that was, in the moderate range, but majority were within the severe range, so at the 50 mark, and they didn't have type 1 or type 2 diabetes. So again, like a quote unquote diabetes medication that is used for weight loss purposes with the goal of improving sleep apnea. And you can see here that it did meet its primary outcome. It resulted in a significant improvement in the severity of sleep apnea compared to placebo. So in general, in both groups 1 and group 2, the AHI went down by 25 and 29 events per hour compared to in the placebo trial. It just changed by about 5. And that was at the cost of the typical side effects you expect with these medications, such as dire like gastrointestinal side effects. You can see here that in this table, so the percent change in the AHI was much greater when you use this medication, which is obvious knowing what we know about the relationship between weight and AHI. What was impressive is that when using this medication, a substantial number of people had improvements in their AHI down to the point where you would maybe not even consider treating them for their obstructive sleep apnea, which is pretty impressive. So using this medication, for all its purposes can, significantly improve sleep apnea in people and perhaps make it so that they don't have to use any other treatment modalities such as CPAP or an oral appliance. There was also improvements in blood pressure using these medications as well. So yeah, this is a very promising thing. The medication I don't think has yet been approved in Canada specifically for treatment of OSA. You can use it for weight loss, but I don't think private insurers have caught up to the medication yet, and it's very expensive. So these medications, when I last attended the talk, they were about $800 a month. So that will probably be the biggest barrier. And then many of these patients discontinue these medications due to side effects at about 1 year. So I know we're running out of time here. I'll just skip to the last kind of newer thing here, and then we can get to just some discussion. So this is also something that has been, it's been around for over a decade. Like the first trial was published, I think, in 2014 for hypoglossal nerve stimulation. I believe is in the New England Journal. And, it seems like a very promising device, and it would be nice to have this tool, but it's not available in Canada. The reason it's relevant is because it is done in the United States. And, patients who go down and vacation in the United States will, there's a lot of commercials and advertising for these certain devices down there. But it's pretty neat. It's essentially like this pacemaker looking device that they implant, the ear, nose, and throat surgeon implants, and then they connect a lead up to the hypoglossal nerve, and then they connect another lead to the fourth intercostal region here. So it can detect when the person is taking a breath in, and then it can stimulate their hypoglossal nerve to like move their tongue out of the way, essentially, and use that to treat obstructive sleep apnea. They have to have fairly specific criteria. So on the left here is the criteria, the current FDA approved criteria to get one of these devices. But the criteria in the brackets is what they used in that initial trial for the only device that's approved, for market use. So, they have to have a BMI that is below 40, but in the trial it was below 32. The trial only enrolled people who had less than 60 events an hour, but that's been increased to 100 events an hour now. They have to have exhausted all other options. And the reason for that is because even though you can very, very carefully select these patients to put in this device, it still costs around $50,000. And because it is a surgery, there are more side effects than, say, like CPAP. And still about a third of people who get this device implanted will not respond to it. Before putting it in, they have a ear, nose, and throat surgeon who is specialized in this sort of thing, observe the collapse of their airway during drug-induced sleep endoscopy. And for people who have, complete concentric collapse of the airway during that, then they are not candidates because moving the tongue out of the way will not do anything to help reduce that concentric collapse. They really want that kind of AP collapse of the airway in order to put one of these things in. And they have to have a reduced amount of central and mixed apnea. So if they have more than that, like this isn't a treatment for central apnea. So you would not expect someone to respond if they have a big proportion of that. It can be quite effective in those people. So you can see here over 5 years that a substantial number have a reduction in their AHI down to less than 15. So again, a level at which you wouldn't really even consider treating, or you may not consider treating sleep apnea depending on a person's symptoms. Although a lot of people still don't have that reduction down to that level. But it has improved the quality of life and improved symptoms in that. So it would be nice to be able to, use this for certain patients, but currently is not available in Canada, and I've yet to refer anyone anywhere to have this sort of thing done. So that's all for today. So OSA is very common. It's underdiagnosed. So, as an anesthesiologist, I expect that you are well aware that you're seeing a lot of these patients and know to screen for sleep apnea in everyone because it is so common. There have been improvements made in diagnostic modalities, specifically that PPG or PAT technology that I expect we'll be seeing more of in the future, especially as the traditional flow-based home sleep apnea tests are phased out. I think, if you had listened to this talk 5 or 10 years ago when it was last delivered, I'm sure that the treatment, the diagnosis, the treatment of sleep apnea actually appears to be very similar. Still, most people get, a level 1 or level 3 study. Still, most patients get put on CPAP. If that fails, most patients get put on oral appliances. But there's just more and more buy-in for this, personalized approach using both endotypes and phenotypes that I would hope that in the next 5 to 10 years, more personalized therapy is available and is more widely used, so that you can, treat people and make them feel better.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.